With conflicting data on the use of PAH medications in these complex group 3 patients, how do I match my ILD-PH patients to any therapy? I think that the INCREASE study has gone a long way to answering this question, but let's work our way through the next set of slides. Things to be cautious about, and I think whenever we start patients on treatment such as this for parenchymal lung disease, you have to be wary about worsening VQ mismatch. This was not seen in the INCREASE study. There is the concern that the patients might have PVOD, such as scleroderma patients, or any patients with fibrotic lung disease can have PVOD-like lesions. Occult heart failure is also a concern that you might unmask this with a pulmonary vasodilator. And patients who have too extensive parenchymal lung disease, where the burden of lung disease is so great that maybe giving them a pulmonary vasodilator is not going to work. None of these signals really came out from the INCREASE study. I just want to underscore that. This slide here is taken from the 6th World Symposium. I was privileged to be the co-chair on the task force that wrote the statement on group 3 pulmonary hypertension. And this is one of the algorithms that was from the paper in terms of when to suspect pulmonary hypertension. And there are many different things that might clue you into the existence of underlying pulmonary hypertension. Patients who are hypoxic, who walk less, desaturate more, have big PAs on their chest CT, have elevated NT-proBNP or BNP. All of these can be important clues to the presence of underlying pulmonary hypertension. Certainly as well, dyspnea out of proportion to the extent of the parenchymal lung disease is another important clue that pulmonary hypertension might be there. Echocardiography is a very good screening tool, but it can both overestimate as well as underestimate the pressures. And as with any form of pulmonary hypertension, in order to confirm the diagnosis, a right heart cath is always needed. One of the things we have struggled with traditionally has been, when is it group 1 versus group 3? And the purpose of this slide and the way it's colored is to show that it's a continuum. It's very hard to be prescriptive and say, well, if you have this FBC and this mean PA pressure, then it's group 1, and if it's the other way around, it's group 3. So it's more kind of a gestalt, and in terms of putting everything together. So we look at the severity of the underlying hemodynamics, we look at the severity of the underlying lung disease. Specifically, it's important to look at both the physiologic impairment as well as the morphologic severity. When I say morphologic severity, I'm talking about the CT appearance, because sometimes the PFTs underestimate the burden of the parenchymal lung disease. A good example of this would be combined pulmonary fibrosis and emphysema, where you can have normal lung volumes, but you can have severe parenchymal lung disease because the mechanical forces of the restrictive process are counterbalanced by the mechanical forces of the obstructive process. What we said here is referred to, in terms of deciding on treatment, refer to an expert center, and hopefully with the results of the INCREASE study, we will have inhaled treprostinil as a medication to offer these patients. Of course, this remains to be FDA or EMA approved, but the data looks quite compelling, although I have to admit to being a little bit biased. This is also another concept slide going to the notion that pulmonary vascular involvement is a spectrum and a continuum. At the top there, we have the mean PA pressure, and we've kind of struggled with this in lung disease. What is the optimal cut point? And as you have more pulmonary hypertension, you have more impairment. So what's the best cut point? Is it 50, 35? Is it 25? Is it the new definition of an MPAP greater than 20 with a PVR of 3 or more? As we go up on the pressures, we go down on the number of patients. There just aren't many patients with lung disease who have mean PA pressures of 50 or more. So let's move that around a little bit. An important concept from this is that rest parameters do not necessarily reflect what happens with exercise. So here we're going to see what happens in a concept patient who starts to exercise, and they might have a resting PA pressure of 20, but it might go up to 35 with exercise. So backwards and forwards, we don't know where their pressures will go once they start being active. Another concept slide is in terms of which patients with IPF to target. There is not a good correlation, as you can see from the slide, between the FVC and the mean pulmonary artery pressure. It's a little bit of a scattergram. So who do we target with treatments? Is it those patients with more severe pulmonary hypertension, MPAP 35 or more? Is it those patients who have less restriction, an FVC of 50% or more? or do we take it down to 25 or even down to 20? This brings up the notion of a rolling threshold. In other words, balancing the pressures with the burden of the parenchymal lung disease. This is another way of looking at it. This is a three-dimensional representation of taking these different aspects of the patient's disease severity into account. So what we see over here is a hypothetical CT score. On the x-axis, we have the MPAP, and on this axis over here, we have the forced vital capacity, and three example patients where you take into account the extent of disease based on the FVC, the CT score, and then superimpose what the hemodynamic profile is. So in summary, pulmonary hypertension associated with interstitial lung disease is a clinical conundrum. ILD and PH pathologies are progressive and may fuel each other's fire. Previous clinical trials have not consistently demonstrated either efficacy or safety of currently available PAH medications in group 3 pulmonary hypertension. Determination of which group 3 patient to treat for the dysfunction of pulmonary vascular regulation is a difficult decision. Several PAH therapy studies have uncovered serious safety issues with group 1 medications in the group 3 population, vis-a-vis the RISE-IP study and reosiguat. More recent studies targeting the vasculature in ILD show significant promise, but certainly most promising is the INCREASE study, once again the largest randomized control study in group 3 pulmonary hypertension, which was decidedly positive, not only based on the primary endpoint, but on multiple secondary endpoints as well. Factors such as the forced vital capacity, the mean pulmonary artery pressure, and the burden of the parenchymal lung disease must be carefully weighed to determine the best management strategy. Thank you all very much.